Good evening, and on behalf of Nari and Femme divisions of Jackson Pal, we welcome you to the Journal Club today. Up to date with updates. This is organized by the Haryana chapter of ISAR, and today's topic is on frozen embryo transfer cycles. This webinar is brought to you by Jackson Falls Cystelia M, Divatron SR, and Lycored M tablets. Just like to brief you a little about Cystelia M. Cystelia M is formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. Divatron SR 20 mg micronized and sustained release tablets of dydrogesterone to improve compliance and enhance outcomes. Divatron 10 mg tablets are also available. Lycored M tablets of natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine. For added advantage, Lycored M contains two proprietary complexes, natural lycopene as lycobeads from Israel, and L-carnitine and L-tartric acid in the ratio of 2:1, which gives the highest available L-carnitine, which is Carnipure, sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. Please note, this webinar is streaming live on Facebook and the link has been shared in the chat box. And to refer to this webinar in future, you can visit our YouTube channel, which is Jackson Pal Medical Insights. We now invite Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR and Director, Roots IVF at JJ Institute of Medical Sciences, Bahadurgarh. Ma'am, please initiate the program.
Yeah, thank you so much. Thank you, Dr. Deepika Jackson Paul, for giving us the opportunity and the platform. This is actually a very, today we are on this episode 12 of Up to Date with Updates, and ISAR Haryana with its motto of Prayas Evam Vistar is always trying to expand both our knowledge and our sort of expanding our viewpoint. So today again, we on this journal club, we have a very interesting topic, and we are always thankful to our to the think tanks of ISAR. We are thankful to our president, sir, Dr. Ameet Patki. Dr. Ameet Patki, sir, is, do we have the CV, Dr. Deepika? So I can briefly, though all ISARians do know about sir being a very academic person who is always at the behest of great events that we organize. And he is the honorary associate professor at the KG Somaya Medical College, and he is consultant to Khar Hinduja and Surya hospitals, has 35 publications and has more than 50 book chapters, and is editor of 3 books. He has also 2 international patents in infertility stem cell research, and he's a TEDx speaker. Then we have also Dr. Asha Bakshi ma'am, who is our honorary secretary of the General National ISAR, who's also the lead consultant at the Asha Bakshi Fertility Center. And ma'am is kind enough to always be with us whenever we need her, and to always guide her. Then we have the other think tanks that our past president, the past national presidents, Dr. Nandita ma'am, President-elect Dr. Sunita Tandulwadkar ma'am, our vice presidents Dr. Madhuri Patel, Dr. Sujata Kar, and the chairpersons of embryology, Dr. Charuda Joshi, and vice chairperson, Dr. Keshav Malhotra. So these are always at our back, always, so we feel always very supported and very confident. and with our team ISAR Haryana, our secretary, Dr. Meenu Handa, clinical secretary, Dr. Manju, and treasurer, Dr. Lakshmi. We are a very close-knit team which always tries to bring more and more better knowledge and better sort of activities, both on the webinar end as well as in our personal meetings. So here now I invite Dr. Meenu so that we can now start the program.
Thank you, Dr. Jyoti. So for all the delegates and for all the esteemed faculty who's joined today, it's our pleasure to bring our 12th episode. And the topic for today for our journal club is embryo retention and the live birth in frozen embryo transfer cycles, a cohort study. Now, this is a very, very important clinical topic, and we hope that we are going to brush this journal club and see what all insights we can get and improve our clinical practice on this. So here I would like to invite our expert for the session, Dr. Sunita Arora. Could I have the CV, please? Dr. Sunita Arora is currently the chairperson for Delhi ISAR, and she's also the director at Dr. Arora Fertility and Gynae Clinic at Safdarjung Enclave and HOD at Department of IVF at Fortis La Femme Hospital at Greater Kailash. So we welcome Dr. Sunita Arora, who's the expert here, and a warm welcome to our presenter, Dr. Surbhi Gupta. Dr. Surbhi Gupta has completed her FNB from BACC Bangalore under the mentorship of Dr. Kamini Rao. And she's also contributed to various chapters in some of the eminent textbooks of infertility and presented papers in various national conferences. And she is currently working as a consultant IVF and fertility at Motherhood Hospital, Gurugram, and has been the associate at Cloud9 Hospital at Sector 47 in Gurugram. So over to you, Dr. Surbhi, and we welcome you for your journal club presentation.
Thank you, ma'am. Thank you for giving me an honor to present this journal club on such an important topic. Okay, so the topic for today is embryo retention and live birth in frozen embryo transfer cycles, which is a retrospective cohort study. The objective of the study was to study the effect of embryo retention in the transfer catheters and pregnancy outcomes in frozen embryo transfer cycles. It was a retrospective cohort study. So embryo transfer is the final and most crucial step in an IVF cycle. The incidence of embryo retention is attributed to be about 1.4 to 2.8%. So what are the factors which affect embryo retention? The foremost factor is the experience of the physician, how experienced the physician is, the number of embryos transferred, whether it's a single or multiple embryos transferred, volume and type of transfer media, but the most significant factor which contributes to embryo retention is contamination of catheter with blood or mucus. Going to the study design of the study, it was a retrospective cohort study. The frozen embryo transfer cycles were taken into consideration from January 2016 to December 2022 in Northwest Women Children's Hospital. The total number of patients were 39,118, out of which controls were 38,933 and cases were 185. Cases means in 185 out of these women, we had embryo retention. The women in the embryo retention group had been propensity scored matched with those in the control group of 1:4 ratio. That means for 185 women who had embryo retention, there were 740 control women. So what is propensity score matching? Propensity score matching is a statistical method used in observational studies to create groups that are similar in their characteristics, aiming to reduce the bias in treatment effect. So basically, we are matching the baseline characteristics so as to reduce the bias. So what were the baseline characteristics which were taken into consideration? Maternal age, maternal BMI, infertility duration, endometrial thickness, number of transfer cycles, infertility type and cause, fertilization type, endometrial preparation protocols, and embryo condition. That is, what is the embryo stage, the number, and the quality of the embryos. So just a brief on what were the protocols and how they were taken into consideration. Different ovarian stimulation protocols according to the maternal age, maternal BMI, basal FSH, and antral follicle count were used. So there was not a single stimulation protocol which was taken. There were multiple, various types according. It was an individualized controlled ovarian stimulation. The trigger was given when more than 2 follicles were more than 17 mm. It was a HCG trigger, either 5,000 or 10,000 units. Oocyte retrieval was conducted 36 hours subsequently. IVF or ICSI based on semen parameters. Then zygotes were cultivated in G1 plus media up to day 3 and then transferred to G2 plus media till blastocyst stage. Then blastocysts were assessed according to Gardner scoring system. So embryo transfer procedure as a standard procedure under ultrasound guidance. The embryos were positioned 1 to 1.5 centimeters from the fundus, and it was an afterloading technique which was used with 20 microliters of media. Post-transplantation, check for the existence, whether it were checked for retention or any mucus. If there were any retained embryos were identified, immediately reloading was done for a secondary transplantation. So endometrial preparation and LPS. Again, endometrial preparation was individualized, either a HRT, down-regulated, or natural cycle. Luteal support was given either in the form of vaginal progesterone gel or vaginal progesterone gelatin capsules, along with oral progesterone, which was given to all the patients. So what were the study outcomes which were studied in the study? The primary outcome was live birth, which was defined as delivery of a live infant after 24 completed gestational weeks. The other secondary outcomes which were studied was clinical pregnancy, biochemical pregnancy, ectopic pregnancy, and miscarriage rate. Clinical pregnancy was defined as presence of a fetal heartbeat on transvaginal ultrasound at a gestational age of 6 to 8 weeks. In ectopic pregnancy, the denominator used was biochemical pregnancy, and in miscarriage rate, the denominator used was clinical pregnancy. So these were some results. The patient characteristics, the participant characteristics, the overall incidence of embryo retention in this study was 0.47%. So after propensity score matching, the differences, standardized differences, were found to be less than 10%. So we can see before propensity score matching, the difference can be 11% in maternal age, 12% in BMI, 17% in endometrial thickness. So, but after propensity score matching, all the standardized differences has led to less than 10%. That means it has been perfectly matched, and the ratio was 1:4, as we have discussed earlier. So now what are the pregnancy outcomes? So we see when it is with embryo retention, there is reduced likelihood of biochemical pregnancy, clinical pregnancy, and live birth. And the P ratio was significant. But there were no changes in ectopic pregnancy, miscarriage rate, gestational age, or cesarean section. So we can see here, the p-value is less than 0.001 when it comes to biochemical pregnancy. Even for clinical pregnancy, it's less than 0.001. And for live birth, it's 0.004. So that means it's a significant p-value. So again, even after propensity score matching, the result remains the same. So there's reduction in biochemical pregnancy, clinical pregnancy, and live birth rate. Also, it was observed that the birth weight was increased in patients within the embryo retention group, the p-value contributing to 0.021. So this table shows that even in subgroups, there was no change in any observation. So when we compare the subgroups as like maternal age, maternal BMI, endometrial thickness, number of embryos transferred, whether it was stage 3 or stage 5, our results remain the same. That means there was a decrease in live birth rate, biochemical, pregnancy and clinical pregnancy in the patients who had embryo retention. So this is just a gist of the results. A decrease in live birth was noted in all subgroups of embryo retention patients, including factors like maternal age, maternal BMI, number of transfer cycles, endometrial thickness, endometrial preparation protocol, stage of the embryo, and number of good embryos transferred. So general incidence of embryo retention in the transfer catheter in blastocyst transfer was comparable to that observed in cleavage stage embryo transfer. So there was no difference whether we transfer day 3 embryos or whether we transfer day 5 embryos. The incidence remains approximately the same. Then, as we have discussed, the birth weight in the embryo retention group was higher compared with the control group. Whereas in the gestational week also, it had an upward trend, but no statistical significance. So if we go to the slide up, so this is the gestational age. In control group, it was 38 weeks. In embryo retention group, it was 38.53 weeks. So, but there is no significant difference. So, embryo transfer is a retention. It's occasional, but it is inevitable. The overall incidence of embryo retention in this study was 0.47%. Now, this study is the first to investigate on a large scale and with rigorous matching the influence of embryo retention in the transfer catheter on pregnancy outcomes. Embryo retention in the transfer catheter significantly reduced the chance of biochemical pregnancy, clinical pregnancy, and live birth. No significant differences in terms of miscarriage, ectopic pregnancy, cesarean delivery, and gestational age was observed. Now, in this study, we saw that the embryo retention was just 0.47%, whereas normal, it's supposed to be 1.4 to 2.8% as per previous studies. So why there was a lower incidence of embryo retention in this study? The first reason is technique per se, that after embryo transfer, we rotate the catheter before it is removed so as to reduce the negative pressure, and we facilitate contact between catheter tip and endometrium. Secondly, the study was confined only to frozen cycles. So in fresh cycles, due to elevated estradiol levels, there's increase in cervical mucus, and cervical mucus can cause entrapment of the embryos, and thus an increased incidence of embryo retention. In frozen cycles, this is not the case. So the most significant factor contributing to embryo retention was presence of mucus in or on the transfer catheter. Mucus may obstruct the catheter's opening or induce adherence of the embryo to the catheter during withdrawal. So we should ensure sterilization of vaginal and cervical areas using sterile warm water. And we should also try to remove the mucus gently if we see any mucus before embryo transfer. So coming to the strengths and limitations of this study, the strengths were, it was a large-scale research conducted with rigorous matching to detect the impact of embryo retention on pregnancy outcomes, thereby augmenting the robustness of our conclusion. 185 patients were matched with 740 patients. Then analysis exclusively confined to frozen transfers, which decreases potential confounding factors like endometrial preparation protocols, and proper statistical methods used to ensure the stability and reliability of the results. The limitations were clinical heterogeneity observed among patients, which inevitably introduces potential bias. Then it was a single center study only. So the study was conducted only in one center. So again, the results can be influenced. The third was low rate of embryo retention reduced the power to detect statistically significant effect modification, thus diminishing the ability to identify significant differences for rare outcomes like ectopic pregnancies. So basically, there was a low rate of embryo retention. So statistical significant modifications which we can consider in the study we were like not able to find out those rare outcomes because of this. So embryo retention is in the transfer catheter decrease the likelihood of biochemical pregnancy, clinical pregnancy, and live birth in FET cycles. Therefore, it is of vital importance that women who underwent repeated embryo transfers should receive more attention from obstetrician to improve pregnancy outcomes. So in women who have undergone multiple embryo transfers after 2 to 3 cycles of embryo transfers, if they have conceived, then again the obstetric and the pregnancy should also be followed very diligently and very carefully. Thank you.
Thanks, Dr. Surbhi. I think this was a very good discussion. Dr. Surbhi, can you go to that slide where we were looking at the birth weight when we wanted to compare the outcomes? So I wanted to understand that, was it anything mentioned in the discussion that, why in an retention embryo group would there be a significant increase in the birth weight? That was any reason that
that was just an observation. There was no reason mentioned there.
Right. Because when you look at that, there should be no reason why from a retention embryo group would be increase higher birth weight. So that ways, right. And
so for both gestational and birth weight, like they found that increase, but in one they found statistically significant difference, in other there was not statistically significant difference.
Right. And I think this is a very important study because, a lot of times we do encounter the retention embryos, but as we know that the statistics is around 1.5 to 2.5% almost. So this is an important study to understand. And also, I think the study, the strength also is because the propensity scoring system that they had done, which was matching of all the parameters. So that also leads to the, a strength of the study, isn't it? Like apart from matching all of these factors of maternal age, BMI, but infertility duration, and also the type of infertility, this is also equally important because sometimes, we could have somebody with cervical stenosis or something else. Even that group has been matched. And also the frozen embryo transfers and fresh. So I think that is the strength of the study.
Also, I think, Dr. Meenu, the number of cases that they have taken is quite good.
Yes,
it is somewhere around
almost
40,000.
Yes.
So that they've taken a number of patients, and among them around 185. How much percent it would be out of those cases? 185 out of the total number that they had retention. So that means
0.47% was the embryo retention rate.
How much?
0.47%.
0.47, okay. So
which is actually lower than what is quoted in
what is quoted in other studies. Yes.
And another thing was one patient of embryo retention, they've almost taken as a 1:740 is the control. So again,
1:4.
1:4.
Whether they have taken the retention, I mean, how many were the people who did the transfers? And was there anybody where depending on the operator, because it is operator dependent, it is like dependent on the person who's doing it. So maybe some people would have more of, if it is a new person doing an embryo transfer, or a person who is not that apt at doing it may have not done it properly, and thereby the retention was there. So one has to be even, I don't know whether the study does mention whether how many were the operators and whether there was anyone, the increase of retention was more with one particular person rather than comparing to the other people, because that basically there are mainly two factors leading on to retention. One is how you do it and how you withdraw the catheter. If you withdraw it without, because if there's an increased negative pressure, there's more chances of retention, the embryos coming back again in your inner catheter, or getting blocked somewhere between getting stuck up to the outer tip if you've not done it very properly. So, or also the second thing is if there is excess of mucus which is blocking your catheter tip. So these are the mainly two things which can lead on to this. So depending on what technique you use and how efficient you are, how many ETs you've done, so maybe that also would be responsible somewhere.
Yeah, very true. I think even Dr. Surbhi has mentioned in this study also, but the reasons primarily has been on the person, on their technical skill, one. Two was on the mucus, on the transfer catheter. So removal at the cervical canal, the mucus, that is very, very important and a critical step during an embryo transfer. And I think what we are trying to imply is that the way we do the embryo transfer, the pushing force and a controlled speed of is a very, very important factor. And I think in one of the studies, they had also mentioned that training and reassessment of the operators to keep bettering their technical skill is a very important factor in reducing the retained embryos. Thing.
I think there's another question by Dr. Yukti there. How long was the retention? So, how long was the retention? Yeah, I think that also makes a sense, because if the retention time is more, our pregnancy rates also would maybe fall if the retention time is longer. So,
I think in one of, yeah, Dr. Surbhi.
Per se, there was no retention time mentioned, but they say that as soon as they checked, in almost 182 patients, they had again secondary implantation. When it was done, it was perfect. But in 3 patients, they had to do third time.
Yeah.
So there
And
was
I think
retention twice in 3 patients.
there has also been one of the studies where they have mentioned, they have seen the clinical pregnancy rate between absolutely a single shot embryo transfer versus the rescue embryo transfer, which is done just immediately. And there has been no significant decrease in the clinical pregnancy rate. So if you do absolutely in all those patients where a rescue ET is done immediately, then there is no. But yes, I think in this study also it is not mentioned that how many patients required the third attempt or, the fourth attempt. Yeah.
What is your personal experience, Dr. Surbhi? What do you feel? Have you, in your retention cases, did you find there was pregnancy in those cases, or can you?
I have, in my
recall?
experience, I have seen 5 patients in retention, in which 3 patients there were pregnancies. In 2 patients, it was not.
Right. So even I feel that retention to me that did not change my pregnancy rates, because we do it immediately. Once we withdraw the catheter, immediately within half a minute the embryologist comes to know and rings the bell ki, okay, the embryo, there is wait, we have to reload it and redo it. So it doesn't take much time. So I don't know, I did not find much difference of the pregnancy. I mean, one should not get worried ki, okay, they have got retained and we are doing it again, so there is any problem. I mean, we should be not hopeful of the pregnancies. What about you, Dr. Meenu? How do you feel about it?
Yeah, I've also personally seen that in all those patients where we transferred immediately in the very first, when we came to know. So if it was done immediately, there was no significant drop in the clinical pregnancy rate per se. So I think that's very important to understand that, yes. And also another thing which is very important, I think practically is that, whenever we are doing an embryo transfer, all of us are still in that same position till the time we don't get a confirmation from the embryologist stating all clear.
Yeah.
So that is it. Also plays a little psychological impact on the patient that, if suppose they do get a negative result, so they don't think about it that, there was a decrease in the pregnancy rate. So I think psychologically also motivation is important, and this practical step by the entire team to be just, still and getting a confirmation from the embryologist and then only, calling it, that ET has been done. So I think that's also equally important.
What is your routine, Dr. Surbhi? Routinely, are you doing removing the cervical mucus, or you are making it very specific only if it is excessive, or what do you do and how do you remove it?
Ma'am, routinely, yes. If there is excessive, then I take extra time. But if it's little bit, then sometimes I ignore, depending, it's like not a generalized rule. but usually using a swab sticks and sometimes an IUI cannula from the external cervical canal.
Okay. Dr. Minu, and how do you do it? Do you do routinely removing cervical mucus, or you are selective?
See, I am selective, but what I've seen is that, most of the patients do have some kind of, maybe not very thick, but some kind of cervical secretions are there. So even with a swab, just taking a bit of, removing it, the cervical canal, just to ensure that, it has to be done very gently, that there is no bleeding as such, and then just cleaning it a bit. I think that is very important. But yes, if they do have a very thick cervical mucus, then take your time and with gentle, warm saline and dipping the gauze into it, and then take, with the removing the cervical mucus. Sometimes you need to use a BD syringe just to be very gently taking with a suction and, negative pressure and then removing it. But yes, this is a very, very important step which should not be missed. Even because, many times what happens is that on the external loss, we may not see a cervical mucus which is there. But maybe in the canal, the cervical canal, there could be a little bit of mucus. So that is the reason why a gentle swabbing it helps. And I think Dr. Jyoti, what about you? I think it's...
Yeah, I also do it very selectively, because normally I've seen when we are using a lot of, we are trying to remove it very meticulously, it starts bleeding. So that is why I really feel that if it is a little bit, one can, anyhow, our inner catheter is still inside. We use, once we put the outer one, when I'm done with putting my outer, then only I introduce the inner one. And then the inner one, absolutely, once it crosses, we can see it under ultrasound guidance. So there is no chance of mucus being interfering anywhere then. Once we are sure that our catheter has, the inner one has clearly crossed the outer tip.
Yeah. So I think we need to be selective and ensuring that there is no bleed. That's equally very, very important part of, gently removing the cervical mucus.
Yeah. Yeah. So I think Dr. Sunita was stuck up with an emergency. So if there are any other questions from our attendees, we can take. Only one question was there that we have already taken. Any other thing anybody would like to comment? Otherwise, any more discussion, Dr. Minu, you would like to do, or should we any take-home messages? Any any comments?
Dr. Surbhi, we can start with doctors.
Yeah.
Ma'am, it's like just main key embryo transfer is the most critical step in our IVF cycle, because that is one step which determines the success. And as clinicians also, we are very stressed about each and every embryo transfer. So, but then we shouldn't be perturbed by like if embryo is retained. So like that negative thing should not come. But yes, we should take each and every precaution while doing the embryo transfer.
I think one should do a lot of hands-on embryo transfers on our what you call dummy that way, so that we can at least we are sure. Then we can understand by that tactile thing also, we can understand that once we cross the internal os without even ultrasound guidance. Sometimes when we just go through the internal os, we can understand, though ultrasound guidance is the best, but one should have a lots of training, and that is very, very important, because if we have good embryos and we cannot place them properly, and that mean maximum implantation, MIP, that if we can put them there, at least we feel we've done our best. Then it is left to our endometrium and our embryo to do the talking and merrymaking, and so that we can get the result after 15 days. But at least we've done our bit and we feel happy about it. So we should be very competent, and we should not leave anything unturned. in making those good embryos and placing them nicely, and then them obviously giving a good luteal support. And if we are getting a lot of all these, if we are, I mean, we should, there is some issue if we are getting many of these back. I mean, if the retention rate is high, that means we are not doing, I mean, we have to change our trick, or we should learn from somebody how to do. Because if while we are removing the outer one, I mean, if we keep the pressure on the inner so that the negative pressure doesn't build and then they don't get sucked in again, that has to be very, very, I mean, one should understand that how we do it.
I think,
So
Dr. Jyoti, yeah, this is a very important point. I think take home also is a very important, it's a practical step of an embryo transfer. That one is, as we were just discussing about the removal of the cervical mucus should be very gentle. It should also be thorough. And if it is viscous, you can even break the strands and then take it out gently. You can use a little bit of media. Also, there's some studies which says that if the cervical mucus is very thick, then you can introduce a little bit of media, break it, and then suck it. And it should be done very gently. And this is a very important point which Dr. Jyoti just highlighted, that while we are from, once the inner catheter is around 1 to 1.5 centimeters from the fundus, and you introduce the embryos, that is a point, because generally if your embryologist is going to be pushing, that is the time when they should not be removing their thumb at all, because once that, if they remove it even for a minute second with a negative pressure, they will be sucked in again. So that's important, that once we have pushed it, we all gently come out together without releasing the pressure. And it has to be in a very controlled manner. The speed should be very, very controlled. So I think Dr. Jyoti just, highlighted a very, very important practical point as far as an ET is concerned. And I think also the fact that
another thing,
Hmm.
Dr. Meenu, I mean, mucus and blood on the outer tape or on the
Yeah,
inner tape, does it
yes,
change your pregnancy rates?
yes, I think that's a very important point, that blood on the, especially on the inner tip, that has been shown in various studies that it will decrease our clinical pregnancy rate as well significantly. So sometimes outer catheter may not, but inner catheter statistically it will decrease our clinical pregnancy rate. And even in this study, there was one point which Dr. Surbhi highlighted, was that I don't know whether it was in this study, that when they have pressed and they have pushed the embryos inside, then the last, they're going to rotate the catheter tip a bit, and so that it has made a connect with the endometrium, and then they take it out. So what is your take on that, Dr. Jyoti? Do you do
I
that?
did not, no, I would not do it. I don't do any manipulation inside because I don't want to
Yeah.
injure the endometrium, and
Yes,
there'll be
yes.
blood. There'll be blood on the inner also and on the outer. And when we withdraw it,
Yeah.
the blood
Dr.
thing.
Surbi, did I read it right? I just
Yeah,
wanted
Yeah,
to,
yeah,
yeah.
you read it right. They try to remove, I mean, rotate
Just
it
rotate
inside.
it so that it
rotate it.
has a, I
So
was
as to
also,
reduce the negative pressure also, because
yeah, no, so I think we are very, we tend to, we are from that school of thought that we like to go just in the middle without touching the walls and
was
coming out. I think,
Yeah.
right.
We'll drive in the center of the road, not on the sides.
Yeah.
No touching the pavements at all. Yeah,
Yeah, I think so. That's good.
right.
So, yeah, so retained embryos, we understand, is a very unwelcome event, but every effort should be made to achieve the lowest incidence possible of a retained embryo during the most critical step of embryo transfer. And I think the last would be the request, training or reassessment of the operators as well, so that we keep refining and polishing such an important step, for which is so prudent for our IVF pregnancy success rates. So thank you so much, Dr. Surbhi and Dr. Jyoti. And it's been a very good discussion, and we hope to get many more very clinical relevant topics to discuss. And I think with this, we would like to conclude the session for today. And thank you so much, Dr. Surbhi and Dr. Jyoti,
Thank
once
you, ma'am.
again.
My pleasure.
Dr. Deepika from Jackson Pal, thank you so much. And we will call this a day.
Thank you so much. Thank you everybody for joining. And we'll put it on our YouTube channel also after we get the recording. Thank you, Jackson Paul, Dr. Meenu, and Dr. Surbhi. Thank you so much.
Pleasure.
Bye-bye.
Thank you.
Thank you.
Thank you all for joining in today. The session today was brought to you by Jackson Pal, Nari and Femme divisions, makers of Cecilia M, Divatron SR, Lycored M, and My Sakhi, which is the CSR initiative of Jackson Pal. For more updates, you can scan the QR code on the screen and reach the website mysakhi.in. So hope to see you again soon.